Hello everyone, I am Dr. Sasi Mouli, consultant endocrine and breast surgeon in Sri Shankara Cancer Hospital, Bengaluru. Today we are here to know more about thyroid cancer as part of Thyroid Awareness Month. So this January is usually taken as a Thyroid Awareness Month, which comprises of lot of thyroid disorders, in which I would be concentrating more on thyroid cancer and its awareness. So coming to thyroid gland, it is present in the neck, and it can have functional disorders or structural disorders. So these functional disorders are in the form of hypo or hypothyroidism, and the normal functionality is called as euthyroid state. So most of us are euthyroid, that means there is a normal function, whereas hypo and hyperthyroid means either less function or more function respectively. That is dealt as a separate topic. Now coming to the structural disease, what happens is there can be nodules in the thyroid gland which is separate from the normal thyroid tissue, and that has to be evaluated further. These thyroid nodules are usually present in approximately 5% of the normal population as well. So now, do we think that is every thyroid nodule a cancer? No, not necessarily. 85 to 90% of the nodules which are seen or felt are usually non-cancerous, whereas only 10% represent a cancerous thyroid nodule. So now coming to thyroid cancer, how do we detect this? Coming to the thyroid cancer incidence, so it is fifth most common cancer in the whole world, and it's the most common endocrine cancer in the world, for which even surgery is been done. Now coming to the thyroid cancer, they present as a nodule which can be present in the right or left side or center of the neck with or without any lymph node enlargement, which are present on the sides of the neck. Now based on the presentation of the patient, whether this thyroid nodule is a small or large, we get to know about the patient. Some patients come with a incidental finding called as incidentaloma while undergoing investigation or ultrasound for any other part in the neck, where they find the thyroid nodule is there, and then they further investigate in the lines of any cancer. Some patients do come with a proper thyroid nodule in the front of the neck which has to be evaluated. So most important is ultrasound. So the first thing we detect is the thyroid function test, that is in the form of thyroid stimulating hormone and T3 T4, and then when the nodule is there, we get an ultrasound of the neck to see how many nodules are there, which side it is involved, and what are the characteristics of these nodules. If there is any high risk features that is suggestive of any cancer, we determine on the ultrasound, and depending on that we get a needle test that is called as fine needle aspiration cytology or FNAC. Now on this there are various categories in which we come to know whether if it is benign or malignant or a borderline. So depending on that we plan the treatment. Also on ultrasound we do see whether if there are any lymph nodes and also the lymph node characteristics, whether they are any suspicious lymph nodes. If at all they are, we get an FNAC from even those lymph nodes to prove that whether the cancer has spread to that lymph node or not, depending on which our management do change. So the main management of this particular thyroid cancer depends on the subtype of which thyroid cancer it is. Most commonly it is called as papillary thyroid cancer, which constitutes almost around 85 to 90% of the thyroid cancers. The second most common is follicular thyroid carcinoma, and third is medullary thyroid carcinoma. A rare variant which is called as anaplastic thyroid carcinoma is pretty aggressive, for which the treatment differs than the other three. So coming back to the first three types, the main modality of treatment is in the form of surgery. Depending on the size and the lymph node involvement, we either do a hemithyroidectomy, that is removal of the half gland, or removal of the full gland. With or without any lymph nodes present, we remove all the lymph node glands of that particular affected site. So after this particular treatment, what we do is we wait for the biopsy report, final biopsy report to come. Once that is available, in case of papillary and follicular thyroid carcinoma, the patient may or may not require something called as radioiodine therapy. That depends on the final biopsy report, which is usually given from 4 to 6 weeks after the surgery, and following which the patient is kept on thyroxine suppression dose, that is a normal hormone which is available in the form of tablet but at a little higher dose than the normal range. So this comprises the treatment, following which the patient is usually followed up every 3 monthly, and if at all needed, then the patient may require some subsequent settings of radioiodine therapy. Now coming to medullary thyroid cancer. So this type of cancer is a little aggressive type of cancer than the other two variants. So the treatment involves removal of whole of the thyroid gland along with any involved lymph nodes, following which the patient may or may not require any adjuvant therapy in the form of radiation. But any of these cancers do not require chemotherapy because they are not sensitive to chemotherapy agents. So one common misconception according to the patients and patients' relative is that after removal of the thyroid gland for a thyroid cancer, does the patient need a chemotherapy? No, not always, or in fact for most of the cancers they do not require chemotherapy except for an aggressive variant, that which I told, that is anaplastic thyroid carcinoma. So here in Sri Shankara Cancer Hospital, we treat all these tumors day in day out. This thyroid cancer is fifth most common malignancy. Usually it presents in a younger age group around 30 to 40. Also it can present across any age groups, but most common is around the second to third decade. Now, what are the predisposing factors? There are some predisposing factors which have been mentioned in the literature, that is either genetic or it can be anything related to the environment, that is most commonly radiation. Radiation exposure also can lead to this, but majority of these cancers can be just what we call as idiopathic, that is there is no cause per se. So when this cancer is detected early, this can be completely treatable and curable. In fact, when it is detected at an early stage, the cure rates are almost 95 to 97%. That means the cancer related deaths for this particular cancer can be absolutely avoided. So the key lies in early detection. For any further information, you can contact our Sri Shankara Cancer Hospital front desk or the website.